Hello and good day, everyone. I'm Frederick Miller, a scientist emeritus at the National Institutes of Health and the National Institute of Environmental Health Sciences. And it's my great pleasure to be with you here today and to share with you some thoughts about increasing autoimmunity and autoimmune diseases, their causes, and the needed actions that we should be taking to try to address this. I wanted to start by pointing out a distinction that confuses a lot of people here, and I'll be talking about later in the talk. And that is the difference between autoimmunity and autoimmune diseases. So autoimmunity is the presence of self-reactive immune elements. That's a big term. But as you recall, the immune system is really designed to help fight off infectious agents or other foreign materials in the body, and bacteria, viruses, and other things like this. And that this does this by two different mechanisms. One is by using antibodies, which are shown in the left upper panel of the cartoons here. And this is a Y-shaped molecule that binds to proteins or antigens, as shown by this blue object. And binds them and thereby activates the immune system to remove or inactivate those things that it binds to. In the case of autoimmunity, these are called autoantibodies because they're binding parts of our own body. And the antigens are called autoantigens because they are parts of our own body. The other part of the immune system is the cellular immune system. In the upper right-hand panel, you see this yellow cell binding to and beginning to destroy this pink cell here on the right. And this is a autoreactive T cell, as it's called. And this is another way that the immune system works to protect us, or in the case of autoimmune diseases, to attack us. So that's autoimmunity. Autoimmune diseases is autoimmunity plus some clinically important pathology. And then these can be the rashes that are shown here, or joint swellings, or some other organ involvement. The next slide shows on a cartoon on the right here, the increasing frequencies of certain autoimmune diseases, and it shows the rather dramatic increases in multiple sclerosis, Crohn's disease, and type 1 diabetes in particular, but many other autoimmune diseases, virtually all of them that have been studied, lupus, scleroderma, myasthenia gravis, myositis, and many others also appear to be increasing in prevalence. And this is both in the US and around the world. And these rapid increases are probably the result of exposures to environmental agents that we'll be talking about a little later. Type 1 diabetes, which you might remember is an autoimmune disease caused by destruction of the pancreas and parts of this pancreas that produces insulin, has been one of the best studied autoimmune diseases. And this slide shows the information about how across the world, type 1 diabetes is increasing on an average of about 3% per year. Dr. Holders and others have found that there are probably stages in the development of autoimmune diseases. And we start out in stage 1 in his scenario with genetic risks. We have genes that make us at increased risk for the development of autoimmune diseases. And then certain environmental exposures interact with those genes to bring us to stage 2, which is called preclinical autoimmunity and inflammation. And then further development in the process with other environmental exposures brings us to stage 3, where we have some initial clinical signs and symptoms, but not yet have met full criteria for autoimmune diseases. And then finally, we have a stage 4, where our doctors can diagnose these diseases. And environmental agents are probably important in the development of all of these stages, which can take, in some cases, only a few days, and others many months, years, or even decades to evolve. I'm going to be talking about some information that came from NHANES, so I thought I'd spend a minute telling you what NHANES is. NHANES is a National Health and Nutrition Examination Survey, which is a CDC program initially designed actually in 1959 to continuously assess the health and nutritional status of people in the United States. It's a unique survey that really uses a lot of statistical sampling to result in a population representative sample of everyone in the United States from analyzing about 5,000 volunteers every year. And blood and other data are collected to create biorepositories as well as databases that can be used for future research. And we and others have used this research to look at the frequency of autoantibodies in the United States. And this next slide talks about how common autoimmunity is in the United States. So here we see an example on the left of thyroid autoantibodies directed against the thyroid component. And as you can see, if you look at everyone, it's around 18% of the US population has these antibodies. And you see that it increases with age, and that women have more than men, as they do almost all autoantibodies and all autoimmune diseases. If you look at people older than 60 and you look at multiple autoantibodies on the right panel here, you see that almost 32% of all people greater than 60 years of age have autoimmunity. It's up to about 40% in women, very high proportion. So this is very common. Now, not all these people have autoimmune diseases, of course. That's the other issue we talked about before. Another group of antibodies are called antinuclear antibodies, and these are antibodies that bind to different parts of the cell. And these are the most commonly used tests to screen for autoimmune diseases, and many of you probably have had ANA tested at one time or another by your doctors. And these are associated not only with autoimmune diseases, but with also other conditions. And these panels on the right here shows what these tests look like under the microscope when you take these cells, overlay them with your blood sample, and then a secondary antibody that is fluorescent that allows you to actually see these antibodies binding to the cells. And we've been using NHANES data to look at antinuclear antibodies in the US population. And this study looked at 3 different periods, 1988 to 91, period 1, 1999 to 2004, period 2, and 2011 to 2012, period 3. And what we found, as we were anticipating, was a rather dramatic increase in the proportion of ANA in the US population over these time frames. If you look at the left panel here, overall, these antibodies increase from around 11% to 12% to about 16% over this whole time frame. Of course, if you look at the different sexes, women have more of these antibodies than men, but as you notice, the male increases have been more dramatic even than the women's increases. Look at ages, again, older people have more than younger people, but the most dramatic increase has been in the older people and in these younger people, the teenagers, ages 12 to 19, in this third panel here, which almost tripled in frequency over this period of time. And if you look at the race and ethnicity distributions, see that African Americans have the highest rates, but that whites are going up rather dramatically over this time frame, and unfortunately catching up with the African Americans. If we look at a lot of different predictors of these antinuclear antibodies, as I mentioned, being a woman or a female is one of the higher predictors. Giving birth to a live child is another predictor of autoimmunity. Being older, we talked about, is also a risk factor. Being non-Hispanic Black, a risk factor. Interestingly, being overweight or obese actually was protective, as well as being born outside of the US. Certain chemicals like triclosan are also risk factors. This is a chemical that's now banned that was added as an antibacterial to many soaps and shampoos in the US and around the world. And of course, having thyroid problems with autoimmune thyroid disease being rather common as a risk factor, but having type 2 diabetes, which is not an autoimmune disease, was a protective factor in males. Well, what may be causing these increases? And again, we don't really know much about this yet. but there's a lot of hints that the environment plays a major role in autoimmune diseases. And this lists some of the reasons why. First of all, low to moderate disease concordance in monozygotic twins. That means one twin having autoimmune disease, the other tends not to. There's evidence if you inject various things into animals, you induce autoimmune diseases. You see the development of these after certain exposures. If you take away these exposures, people get better. If you give them back, they get worse. There's geographic and seasonal clustering. If you move to an area with high autoimmune disease risk, you increase that risk. We talked about the increases over time. These genetic risk factors are actually environmental response genes, and we have a lot of epidemiological data to also support these associations. So overall, we think it's the interactions of genes and environments that lead to these different autoimmune diseases, or the unique features called phenotypes, which are subsets of autoimmune diseases. And they do so by these interactions. And as we mentioned, there's some protective genes and environmental exposures too. What are some of these environmental agents? Well, solvents, things that dissolve various things, from petrochemicals, compounds for the most part, pesticides, occupational exposures to silica, such as those working in mines, smoking, cigarettes, air pollution, sunlight and vitamin D, hormones and our nutrition, our high salt, high fat, and high sugar diets are not good for us in the United States. Infections and the components in our GI tract of the microbiome are also important. This shows how the chemical compounds that we've been exposed to have been also dramatically increasing over this period, with almost a doubling of the chemical industry total materials, while the plastic increases, pesticides, and a variety of other chemicals are going up over this time. It's hard to estimate the cost of these in the US given our diverse medical system, but in places like Korea, where there's a single healthcare system, they found dramatic increases in the costs of autoimmune disease, as this slide shows here. So how can we curb this autoimmune epidemic? Well, I think first of all, we need to get everyone who is impacted together, working together, researchers, government agencies, drug companies, and patient groups, to develop international consensus on how can we best define the best research opportunities, how can we prioritize our efforts, how can we even define autoimmune diseases, because we really don't have a well-accepted definition of these, and we don't even know which diseases are actually autoimmune right now. We have differences of opinion on that. And we need to coordinate our efforts in disease and in our basic research, our animal model research, our clinical research, and define the best way to measure costs so we can prioritize our efforts and coordinate and oversee the other efforts I'll be talking about here. The NIH has a number of offices and centers that are each working in their own areas and unfortunately not coordinating their efforts in autoimmune diseases. And so the National Academy of Sciences has recently recommended, after a review of the NIH efforts, to establish an Office of Autoimmunity and Autoimmune Diseases, which might eventually evolve into an institute. We need to develop registries and repositories for autoimmune diseases around the world, because we can't really study something we can't measure, and we haven't been able to really measure these well. And we need to fund well-designed studies of these diseases, especially with those that have several similar features or pathogeneses, so we can understand their risk and protective factors. As I mentioned, we need to understand those gene-environment interactions so we can actually include groups that are together based on similar mechanisms or risk factors so we can develop preventative strategies. We need to decide how to best diagnose these diseases. As most of you know, it can take years to come to a diagnosis, seeing many different doctors. And if we had better diagnostic approaches, better biomarkers, better testing, we could actually diagnose these earlier and minimize the damage that occurs from chronic inflammation while these diseases evolve. Even after being diagnosed, we'll find differences of opinion from different doctors about how to treat these autoimmune diseases. And so we need to define the best practices for medical care here as well. We need to define better clinical trials and undertake more efficient studies of these patients by doing what are called basket or umbrella studies to basically link these different agents, different diseases that have different agents together. And cancer is a good example that they're using these approaches right now. And then ultimately, we need to actually understand how to prevent these diseases by combining promising blood tests, changing our lifestyles, avoiding risk factors, and perhaps even considering drug treatments to prevent disease once you have biomarkers present. So in summary, autoimmune diseases and autoimmunity are increasing in the US and globally, likely due to environmental effects. Many people have multiple autoantibodies, and autoimmunity is actually common in the US. Greatest increased rates of autoimmunity are seen in teenagers and older adults, and these are very concerning trends. The causes of these diseases are unknown, but we and others are doing studies of changing diets, chemical exposures, sleep, physical activity, stressful life events, infections, vaccines, the use of electronic devices, climate change, and other factors that might be important in the development of these diseases. And these increases, of course, have induced significant upsurges in individual and societal suffering, as well as in private and public healthcare costs. What we need are increased global scale multidisciplinary research and coordination with more funding and more systematic approaches in our ability to understand, diagnose, treat, and prevent these diseases. And these effects would be likely cost effective. I thank you very much for your attention. I'm sorry I've not been able to be with you today physically because of a conflict, and I hope you enjoy the rest of your day. Thank you.